This is Dr. Russell Blaylock, and you're listening to the Blaylock Health Channel. Welcome to the podcast. Today I'm going to discuss a couple of issues that have to do with breast cancer. What I want to do is discuss two main issues. Number one, are women undergoing potentially dangerous breast cancer treatments unnecessarily? That's a very important question. That is, are breast lesions being diagnosed as cancer when in fact they may be benign lesions that will never progress or endanger the life of the woman? And the second thing I want to address is mammography, the dangers. Is it the best way to diagnose breast cancers early? In essence, does it prevent death from breast cancers over other screening methods? Is it the best way to detect breast cancer early? So we're going to discuss those two issues. Beginning first with the issue of the pathology of the breast cancer. How has the diagnosis of breast cancer changed recently? The most common form of breast cancer diagnosis classified as what we call a ductal carcinoma in situ, frequently called DCIS for short. And this was first recognized in 1893, and by 1930 it was considered to always evolve into an invasive metastatic cancer. That is, it would, if you left it alone, it would become invasive, spread throughout the body, and could end up in death. So consequently, they recommended radical mastectomy every time this lesion was discovered. And as a result, hundreds of thousands of women lost their breasts to what essentially may have been a benign lesion. Now, at the time, most breast surgeons and pathologists agreed on this viewpoint, and radical mastectomy, they agreed upon, was the treatment of choice. To do less, it was taught, was to endanger the lives of women. Later, this view was challenged, and some critically thinking breast surgeons expressed the opinion that less mutilating surgery could be done safely, as they felt that many of these so-called breast cancers were not that aggressive and could be cured by simple local removal of the tumor, something we now call lumpectomy. The most common type of breast cancer is, as I said, the DCIS, or the ductal carcinoma in situ, implying an early cancer. The second most common is the invasive lobular cancer. Keep in mind that until now, all the DCIS lesions were considered cancers or lesions that would evolve into cancers, thus necessitating more extensive treatments. So what has changed? The most recent studies now recognize that 84% of DCIS tumors act as if they're benign and have the appearance of a benign tumor or lesion, and may never evolve into cancers. Of all DCIS lesions, only 14% become invasive, that is, become true cancers. Again, this is the most common type of tumor removed as breast cancer. If we look at the 14% of the DCIS lesions to see why they're classified as truly malignant, we see they include what is called DCIS with microinvasion, that is DCIS-M as their designation goes. Now, this form of DCIS makes up a very small percentage of total types of breast cancer, only 0.68% to 2.4%. But of all the DCIS cases, it makes up only 14%. Now, the DCIS-M, that is this microscopic invasive type, pathologically are larger tumors, that is, they're from 2 to 2.5 centimeters or greater. They have necrosis in the center of the tumor when they're examined, and they have obvious malignant appearing cells when viewed under a microscope. In other words, they're easily differentiated on careful pathological examination of the surgical specimen as being truly cancers, thus clearly separating them from the 84% benign behaving type lesions. Now, if we compare the risk of these two types of DCIS, that is, what are their chances of metastasizing or spreading, for instance, to local lymph nodes? We see that this 84% DCIS, that is the benign-looking ones, never metastasize to the lymph nodes. Of the DCIS-M, that is the ones with microinvasion, 2 to 10% will spread to the local lymph nodes. And if we look at truly invasive tumors, those are obviously have escaped into the surrounding breast tissue. 27.6% will metastasize to local lymph nodes. Now, what this means is that only the truly invasive tumors, as seen on pathological examination, are a real risk to women. Current clinical recommendations for DCIS patients state that they should have mastectomy or lumpectomy followed by radiation treatments to the whole breast. That's considered the standard treatment and standard recommendation by the experts. Now let us look at some deceptive wording that's used by the experts in breast cancer treatment. The experts boldly assure women and treating doctors that they're advising, quote, that in cases of DCIS, radiation therapy after surgery can reduce the risk of cancer recurrence by 50 to 60%. Now that sounds like it's a pretty obvious decision that should be made, that you should have post-op radiation. What is not said is that the accepted medical literature studying this issue found that when the surgical margins around the excised tumor are completely clear of tumor, including microinvasions, post-op radiation has no benefit on the risk of recurrence, that is, in preventing local recurrence or spread of the tumor to more distant places. Keep in mind that true DCIS never metastasizes to the regional lymph nodes. That is, there's no evidence it will spread. 84% of DCIS lesions are operated on are of this classification, yet they're treated as if they're truly metastatic tumors. So what about the truly invasive tumors? Well, it is true that post-op radiation can reduce the risk of recurrence of invasive nature of these cancers. But even in this case, if the margin around the tumor when it's surgically removed is completely clear of tumor, even to 1 centimeter around the tumor, there's no difference in recurrence rates between those treated by simple lumpectomy alone versus lumpectomy plus post-op radiation. Now let's look at some actual studies. In one such report, 818 women with breast cancer were studied who either had a lumpectomy alone or lumpectomy plus post-op radiation. Lumpectomy alone had a recurrence of 31.7%, whereas lumpectomy plus post-op radiation, the recurrence rate was 15.7%, which is about 50% reduction in the risk of local recurrence. This would seem to indicate that post-op radiation was of a real advantage, as there was this 50% reduction in recurrence rates. It is essential to keep in mind two important facts. One, all cases of DCIS were included in this study. That is, they included the 84% that never invade and the 14% that do. Second, when we separated out those that had complete removal, the post-op radiation had no value, no benefit in the woman's risk of a recurrence of that tumor. Critically important was the consistent finding that the 12-year survival, that is long-term survival, was exactly the same whether the woman underwent a lumpectomy alone or lumpectomy followed by post-op radiation treatment of the whole breast. The numbers, the percentages were exactly the same. Another study of 1,010 patients found that exactly the same thing. There was no difference between doing just a lumpectomy alone or lumpectomy followed by post-op radiation if the margins were clear of tumor. If not clear, then there was a difference, 32% versus 16%. As for the use of tamoxifen post-op, two studies are frequently quoted. One is called the NSABP24 trial, and they found a reduction in local recurrence, but absolutely no difference in long-term survival, whether you use a simple lumpectomy and no tamoxifen or lumpectomy and tamoxifen. So there was no difference. The other study was called the UKCCR trial, found no difference between either treatment, that is lumpectomy alone, or the combined lumpectomy plus post-op radiation. The results of which were the same as regard local recurrence of the tumor and long-term survival of the patient. So it made no difference whatsoever, and there was no advantage to post-op radiation. This distinction between local recurrence and long-term survival is important because in most women's mind, when the doctor speaks of recurrence, they envision a spreading or metastasizing of the cancer all over their body, not local recurrence. A local recurrence can be cured with a second surgery if detected within a reasonable time. Metastatic cancer is a whole different ballgame, one that I'll address in a future podcast. Now, when you're diagnosed by a mammogram or other procedures having a lesion, the next step is either a biopsy or a lumpectomy or both. Once the tumor is removed, it's examined by a pathologist. Usually, a number of techniques are used so you can classify the tumor as either true DCIS, that is, one that has no characteristics of a real cancer, or it is classified as an invasive cancer, which means that the malignant cells have broken out of the structure of the duct of the breast into the surrounding tissue. This can be grossly obvious invasion or one that entails just a few microscopic cells, as we've already discussed. The tumors also undergo an array of special immunologic staining techniques to determine the aggressiveness of the tumor. Nevertheless, after the pathological examination, one pretty well knows the risk of the tumor ever becoming a life-endangering tumor. Now remember, the recommendation to experts is that all women have post-op radiation treatment, no matter the pathological classification of the tumor. Yet we now have the capability by pathological examination alone to tell which lesions are the greatest danger. Now, if the pathology report finds the tumor has been completely removed and all the margins are clear, post-op radiation should offer no advantage, and that's what the studies confirm, but would expose the woman to a real danger of injury and risk of inducing future cancers of a very aggressive type by the radiation itself. Now let's look at a most interesting study. In one study of 333 breast cancer patients using a pathological classification system that entails taking into consideration the tumor size, the margins width, that is where the margins of the removal clear of tumor, and pathological classification of the tumor. If you took all that into consideration, comparing simple lumpectomy versus the combined lumpectomy and post-op radiation, the former, that is the simple lumpectomy alone, had just a 2% local recurrence rate with a median follow-up of 79 months, that is over 6 years. Now it's estimated that most likely those 2% that recurred really had microscopic invasion. Follow-up studies of those with 1 centimeter clear margins around the tumor had a 4% recurrence rate at 8 years. That means there's 96% of the women did not have any recurrence and did just fine. Remember, in previous studies, DCIS tumors with radiation had a 7% recurrence rate, which is 3% higher than if you just did the surgery alone. In essence, surgical removal of all tumors had a lower recurrence rate than lumpectomy plus post-op radiation treatments. Now, what is involved in post-op radiation treatments? Well, they radiate the entire breast. It requires going to the radiotherapist 5 days a week for 7 weeks. Now, they are experimenting with partial breast radiation, which would take 5 to 10 days. But right now, most women are advised to get total breast radiation over the full period. Now, one of the most important questions would be, is post-op radiation dangerous, especially to women with a BRCA1, BRCA2 mutation? These are genes that control DNA repair enzymes. And the function of these DNA repair enzymes is normally to fix the damage to DNA as it occurs with exposure to radiation of whatever cause. Damaged DNA can convert normal cells into malignant ones, and the breast tissue is especially sensitive of all the tissues in the body to this conversion by radiation. Mutation of the gene means that the enzymes no longer work. In other words, it cannot repair the DNA after it's been exposed to radiation. And these individuals are especially at risk of radiation-induced breast cancer. When women were exposed to radiation from the atomic bomb attack on Hiroshima and Nagasaki, physicians and researchers found a significant increase in breast cancer in these women. And the studies have also shown since that time that women in this country exposed to diagnostic X-rays to the chest, such as a chest X-ray or upper GI series, as well as therapeutic radiation treatments, have an increased risk of developing breast cancer. Usually the lag time is about 15 to 20 years after the exposure. Often these radiation-induced tumors are very aggressive. One must conclude that post-op radiation should not be routine, especially when 84% of women with a diagnosis of DCIS have apparently benign lesions. Now let's look at the second thing I wanted to talk about, and that is the diagnostic test for breast cancer. Much controversy has erupted concerning the safety and effectiveness of the mammogram. Previously, it was determined that women under age of menopause did not need to get yearly mammograms, and it was changed, the recommendation, to getting a mammogram every other year. This appeared after decades of experts insisting that all women should begin yearly exams at least by 30 for the rest of their lives. A new study now questions the usefulness of mammograms in saving lives of older women as well. And after all, the big selling point of a mammogram has always been early diagnosis saves lives, which is true. The question of mammogram safety, that is, repeatedly exposing the breast tissue to radiation year after year, have been dispelled out of hand with very little discussion, even in scientific circles, despite evidence that the radiation does damage and that this damage to the breast is accumulative. It's been estimated that with each yearly mammogram, there's a 1% increase in breast cancer risk. So that over 10 years, that would be a 30% increased risk of breast cancer because it's accumulative. That is, with each yearly exam, some of the radiation-induced damage to your DNA goes unrepaired, and therefore accumulates. Over time, this could lead to the development of a cancer. This cumulative radiation damage to the DNA is of particular concern for women having that BRCA1, BRCA2 mutation to their DNA repair controlling genes, because they can't fix the damage. It should also be appreciated that women with breast cancer, true breast cancer, are found to have hundreds of genetic alterations, and these are different than those found in the normal genes of normal breast cells. Now let's look at a new study. This was reported in the British Medical Journal, February 2014 issue. This was called the Canadian National Breast Screening Study. This was a random screening trial, and the sole measure for its outcome were deaths in these women from breast cancer after a 25-year period of follow-up, comparing, that is, different screening methods. This was a 25-year-long study involving a total of 89,835 women aged 40 to 59. Half of the women had annual mammograms, half had annual physical exams only. Of the tumors detected by both methods, an equal number died in the mammogram group and the physical exam group only. The findings for women aged 49 through 59 were identical. That is, mammograms did not prevent any more deaths than did just doing a physical exam alone. In essence, the study found that annual mammograms were no better than annual physical exams in preventing women from dying of breast cancer over a 25-year period of study. Now, that's important to understand, because what you're interested in as a patient is, what are my risk of dying? If I don't get the mammogram, am I at a greater risk of dying? The results of this study and some other studies demonstrated the answer to that question is no, you're not at a greater risk of dying if you don't get the mammogram. In essence, the study found that annual mammograms were no better than annual physical exams in preventing women from dying of breast cancer over a 25-year period of study. That's a very long study. So what about MRI scans? When criticism of mammograms began to surface, especially about their safety, some people advocated, well, why don't you use an MRI screen? But critics, mainly those who were operating these large mammogram clinics, argued that the MRI was untested and there would be a problem with overdiagnosis because of the high resolution of the MRI scan. That is, MRI scans show a lot more details. Since then, the American College of Radiology has now stated that their radiologists are trained in the use of MRI for breast screening. Besides being able to see the interior of the breast in greater detail and without having to compress the breast, the MRI allows enhancement with a special dye that determines the vascularity of the tumor, that is, how dense the blood vessels are in that tumor, which can aid in determining the invasive and metastatic risk. They also found that over time, accuracy of reading MRI breast studies increased substantially. The MRI has been shown to be superior in detecting lesions in dense breast tissue, which is a real problem in young women. They have denser breasts, and it's more difficult for the mammogram to examine. It is also superior in detecting BRCA1 type tumors. That is, in women who have this genetic defect, the tumors are different, and they are often missed by mammography because these tumors are more cellular. The MRI is especially useful in evaluating residual disease, that is, if there's still some tumor left in the breast after surgery, and occult invasions and multicentricity, that means multiple tumors in the breast, are more easily picked up with an MRI than a mammogram. Also, it may be better for determining the risk of invasive disease, and in those with painful, dense, or nodular breasts, which usually are not suitable for a mammogram. Now, the tumor extent, that is how far the tumor might have invaded, was more accurately determined in the MRI, with 95% of the tumors being accurately examined and determined, with only 74% of mammograms being able to have that degree of accuracy. An article appearing in the 2009 issue of JAMA, which specifically looked at several methods of detecting BRCA1, BRCA2 associated tumors, trying to determine their accuracy. What it was looking at is different ways to examine the breast, whether it was an MRI scan compared to a mammogram compared to ultrasound breast exam alone. Now, we know that the lifetime risk of breast cancer in these gene mutations is 85%. So over a lifetime, they have an 85% chance that they're going to develop a malignant tumor in their breast. And the official recommendation is that these women that have this genetic defect have a breast self-exam starting at 18 to 20 years of age, and then begin annual mammogram scanning starting at age 20 to 35 years of age. In this study, they examined 236 women with BRCA1, BRCA2 mutations, which makes it the largest study of this kind. They compared MRI scans, mammograms, and ultrasound breast exams each. In other words, the women either had an MRI or a mammogram or an ultrasound. The tumors that they eventually detected in these women, the MRI picked up 77% of the tumors, the mammogram picked up only 33%, and ultrasound only 9.1%. So the MRI was more than twice as effective at diagnosing these tumors than was a mammogram. In a previous study in which they looked at 96 patients with this genetic defect, the mammogram diagnosed the lesion correctly in only 36%. So it's a very low detection by the mammogram, with over 60% of the tumors being missed. Now, one of the main problems with this BRCA1 cancer, it tends to be more cellular rather than serous, which is a denser type cancer. And so it tends to look normal on a mammogram. And another large screening study they did of 196 high-risk women, and mainly women who had a genetic or family risk of cancer of the breast. The sensitivity of the MRI scan was 95% versus 34% for the mammogram. Previously, it said that one of the problems with the MRI scan was specificity, that it may be difficult to tell what kind of lesion it is. But now, the latest studies have shown that the MRI scan has a 95% specificity, which exceeds the mammogram. So in summary, it appears that the mammogram is mainly picking up, in large numbers, is the DCIS lesion. The invasive cancers, particularly the multicentric type, is best found with an MRI scan. The MRI scan is more accurate, and the studies have shown that with increasing experience of the radiologist, the specificity exceeds that of mammograms as well. The MRI scan uses no radiation. There's no need for compressing the breast, and when correlated with breast self-exam, it's far superior to a mammogram, especially for the more aggressive forms of breast cancer. We're close to developing ways to determine which DCIS lesion will progress to an invasive form of true cancer, and this will prevent the 84% of women now being exposed to dangerous and unnecessary treatments from having to undergo this medical abuse. And this is being written about. But already we have pathological ways to tell after the surgery to a high degree of accuracy which lesions are true cancers and which are more benign. As far as thermograms go, results suggest that it is better than ultrasound but less effective than mammograms in detecting lesions. Again, the most common lesion in the mammogram and what it's detecting is DCIS, most of which are benign in their behavior. What these studies should be looking at is a comparison of the thermogram versus mammogram in detecting invasive cancers only. The accuracy of the thermogram depends on the expertise of the person reading it and the use of neurocooling techniques, which can help differentiate between benign lesions and true tumors, true cancers. So I hope that this discussion has been a benefit, and I'll bring you some additional information in future podcasts. Thank you. The information contained within these programs is not intended to replace or contradict that of your physician. This information is for educational purposes only.